Welcome to our 13th episode of The Virtual Psychiatrist. This is your host, Muhammad Ali Rifai. I am a professor in medicine and psychiatry. We will be talking today about the state of medicated America.
So nearly a quarter of adults in the U.S. are on psychotropic medications. That's a staggering number, and it really reflects the state of our national mental health.
Yeah. And what really stands out is how much higher that number surged during the pandemic. Isolation, stress, it all created this perfect storm. But do you think it's just that? Or is there more at play here? Well, the pandemic certainly acted as a trigger, but I think the trend goes beyond those 2 years. Our healthcare system is honestly set up to foster this kind of over-reliance on medication. You see, with these 15-minute med management visits, there's hardly time to dive into the root causes of someone's distress. Physicians are kind of, or let's say often, pressured to prioritize quick fixes.
Right, like prescribing becomes the fastest way out. But it's not sustainable, is it? I mean, what happens over time to patients stuck on these meds?
Exactly. It's not sustainable. And one issue we rarely talk about is this. There's no formal guideline for physicians on how to help patients safely taper off these medications when they're no longer needed. Instead, what we see is long-term use by default, not by design.
That's concerning. Do you think there's just not enough research on tapering, or is this more about systemic inertia?
It's a bit of both. Take the National Institute for Health and Care Excellence in the UK. They have structured guidance for tapering antidepressants over months or even years. Here in the US, we don't have anything like that. And without that roadmap, physicians are left guessing. But what's really heartbreaking are the patients who often face withdrawal symptoms or confusion about whether they're relapsing. The lines blur, Teresa.
Yeah, I can totally see that. It's got to be terrifying for someone to not know if they're feeling worse because they're coming off the meds wrong or because their condition is flaring up again.
It is. Let me tell you about a patient I've worked with. We'll call him Alex. He was in his late 40s and had been on a cocktail of medications for years. When he first came to me, he said, "Doc, I don't feel like myself anymore." He wasn't sure if the medications were helping or just numbing him, But when we started tapering very carefully, he began rediscovering pieces of himself he thought were long gone. And the process, it wasn't linear. There were hard days, but he eventually got to a place where he no longer needed most of the meds.
Wow, that's powerful. And it kind of emphasizes what we're saying, right? That while medications can save lives, they can also end up masking issues rather than addressing them directly.
Yes, and it shows just how much we need a paradigm shift. It's not just about prescribing. It's also about deprescribing responsibly. And that work requires time, patience, and a broader perspective that includes therapy, support systems, and addressing the social factors that might be fueling mental distress.
That really resonates, Dr. Rifai. Our office have been working with someone who's going through a similar challenge. His name's Daniel, a sharp lawyer who's been tapering off lithium for months now. Some mornings, he wakes up trembling with anxiety, questioning everything, whether it's withdrawal, a relapse, or even something as simple as a bad meal.
I've heard that so many times before, Teresa. Patients often walk that tightrope where the withdrawal symptoms mimic the very conditions they're trying to manage. And it's not just physical. It's the psychological strain of constantly second-guessing yourself, wondering if you'll spiral down or finally find clarity. That's why structured support is so critical.
Exactly. But here's where it gets complicated. He's also been working with a coach, not a psychiatrist. You know Laura Delano? She's this ex-patient who now mentors people on how to quit medications, but without clinical supervision. I mean, her story is inspiring. She's gone through it herself, walked away from psych meds, and says her life is better for it. But come on, isn't that risky?
Very much so. What she's offering might resonate with people because it feels accessible, but tapering off psychiatric meds is not a one-size-fits-all journey. Without a professional to guide you, you're left guessing, exposing yourself to withdrawal symptoms, potential relapse, or worse. And while yes, there's value in peer support, it cannot replace clinical expertise.
Right. And the grassroots energy behind movements like hers is huge. There's this growing theme of people wanting to reclaim control over their health. But as empowering as that is, there's also danger in thinking you can go it alone. I mean, I'm all for patient autonomy, but where's the net to catch you if you fall?
That safety net is supposed to be clinicians, but here's the crux of the issue. We're simply not equipped with the tools. In the UK, for example, they have the NICE guidelines offering a systematic tapering approach for antidepressants. But here, most physicians haven't even had proper training on withdrawal management. So patients feel stuck between staying on meds forever or venturing into uncharted waters without a map.
And it's frustrating, Doc, because it's not just the patients suffering here, it's doctors too. Like you've said before, the system gives us 15 minutes to manage meds, but no time to do what's needed, like walking someone through an actual taper strategy. It forces both sides into corners.
Exactly. And let's not forget that every case is unique. I've had patients who couldn't handle the slightest reduction in their dose without severe rebound effects. Others tapered successfully because we went at their pace, addressing every change in their symptoms along the way. For some, the withdrawal isn't just physiological. It's this fragile dance of rediscovering who they are without the shield of medication.
Doc, that's deep. Rediscovering themselves, it's powerful. But you're right, the stakes are massive. If these grassroots movements really want to help, they need to collaborate with professionals, not sidestep them. Safety can't be optional.
Agreed. It's not about discouraging people from taking back control of their health. It's about guiding and partnering with them. Structured tapering isn't just science, it's stewardship, which we're going to need to explore further if we're serious about changing this paradigm.
I can tell you from experience with my family, they need to stay on their medications, but have always wanted to go off their medications. Not good.
Teresa, picking up where we left off, structured tapering is such a critical piece, and you're spot on about the need for collaboration. Take what's happening in the UK, for instance. Their NICE guidelines lay out a staged tapering approach for antidepressants. Patients are closely monitored, and the priority is ensuring withdrawal symptoms remain manageable or resolved before every dose reduction. It's a thoughtful, methodical way to guide people safely through a process that can otherwise feel so overwhelming.
That's interesting. So they're really taking what sounds like a much more granular approach compared to what we do in the US. That kind of thoughtful framework is sorely missing here. Why haven't we adopted something similar?
It comes down to systemic priorities, or rather, the lack thereof. Structured tapering takes time that many overburdened physicians just don't have in their schedules. And let's face it, our healthcare system is incentivized for management, not resolution. Contrast that with models like the UK's, where the focus is on outcomes and longer-term patient well-being, not just short-term symptom control.
Right. And that shorter outlook creeps into everything else, doesn't it? I mean, social determinants of health might as well be in a different galaxy given the way our system operates. Poverty, trauma, chronic stress, Those factors are foundational, but there's no space to address them in 15-minute med checks.
Exactly. The need to integrate behavioral health with primary care is critical here. For instance, stress doesn't just affect your mental well-being, it's tied to physical illnesses like heart disease and obesity. Supporting patients with therapy, community resources, and even lifestyle changes can make a huge difference. But when behavioral health isn't easily accessible or embedded in the system, it leaves patients struggling on their own.
That's where we really fall short, right? Accessibility and equity. If someone doesn't have insurance or lives in a health desert, all the holistic care in the world isn't going to mean much. And let's not get started on the mental health stigma that still keeps people from seeking help in the first place.
Absolutely. Now take something like the President's Make America Healthy Again Commission. It's an ambitious initiative targeting chronic disease and mental health reform. If implemented, it could push for greater integration of resources, but also reframe the healthcare narrative toward preventing illness instead of purely treating it. If successful, it might even make some headway in addressing the glaring inequities.
It could be a game changer, honestly. But let's not kid ourselves. It's going to take a monumental shift to overcome years, decades even, of systemic inertia. That said, even addressing simple things like reviewing medications regularly or funding comprehensive community programs would go a long way. The potential is there. But we have to be purposeful about it, Teresa. The UK's model works because they prioritize patient outcomes over pharmaceutical-driven incentives. Could the same approach work here? Only if we first rebuild trust in the system, invest in education for both patients and providers, and create policies that focus on holistic care.
It's no small task, but the stakes couldn't be higher. We're at a tipping point where people are increasingly skeptical of the healthcare system altogether. Any reform has to show tangible outcomes, make people believe in the system again. Otherwise, it's just more Band-Aids on bullet holes.
And that means seizing this moment to rethink every element of care, starting with not only how we prescribe, but how we deprescribe. It's not just policy changes. It's a cultural shift in how we view medicine and recovery in this country. Dr. Rifai, about these giant pharmaceutical companies, what impact do they have on these issues? Picking up from what you said about deprescribing as part of a cultural shift, it's fascinating to me how little attention we actually give to the end game of treatment plans. Once a prescription gets written, it feels like the conversation on how to safely taper or stop it often falls by the wayside. Why do you think that is?
It all comes down to incentives, Teresa. Pharmaceutical companies, for example, have no real motivation to fund research on discontinuation. I mean, why would they? There's no profit in teaching people how to stop using their product.
Right. And let's be honest, most of the time, it becomes the doctor's problem to figure it out later. But even then, the system doesn't really make space for it, does it?
Not at all. If you think about it, Teresa, our health insurance model forces psychiatrists to cram patient care into these ridiculously short sessions. 15 minutes isn't enough time to have a deep conversation about, say, the long-term implications of staying on medication. And it certainly isn't enough to design a thoughtful tapering plan.
15 minutes? Forget thoughtful. That's barely enough time to ask how they're doing and write a refill. It's frustrating because we're putting people on lifelong treatments without revisiting the original question. Is this still helping them?
Exactly. And patients often feel like they're left out of the process entirely. There's this top-down approach in psychiatry where medications are adjusted without enough collaboration. Imagine how different things would be if we actually included patients in those decisions. Not just about starting medications, but also about when and how to stop.
Totally. Because without that conversation, you're leaving people to wonder, is this forever? Do I even have a choice here? And honestly, the lack of clear guidelines doesn't help them or us as clinicians.
You're absolutely right. If we had well-researched, structured protocols, we could guide patients better through these transitions. Look at the UK with their NICE guidelines. They've set up a gradual tapering framework that's safe and patient-centered. What's stopping us from doing the same? Resources, priorities.
It's all of it, isn't it? The lack of funding, the systemic inertia, the focus on short-term fixes. But, Dr. Rifai, I think part of it is also that people don't see tapering as its own skill set. It's treated like an afterthought when really it can be just as complex as prescribing.
So true. And here's where it gets critical. Tapering isn't just a clinical exercise, it's deeply emotional. The process can feel overwhelming for patients, like letting go of a safety net they've relied on for years. Without proper support, they're navigating blind.
And meanwhile, they're asking themselves, is this withdrawal? Is this my original diagnosis returning? Or am I just failing at this process altogether? That's a scary place to be.
It is. And every patient's journey is unique. Some taper quickly, others need months or even years to reduce safely. But all of that takes time, expertise, and communication, none of which are prioritized in our current system.
Well, it sounds like we're not just talking about changing clinical practice here. We're talking about a cultural shift in how we approach mental health care from start to finish.
Absolutely. We have to move toward a system where we value recovery over mere symptom management. That means bringing patients into the conversation, educating physicians about deprescribing, and shifting the focus from quick fixes to sustainable health. It's a holistic reimagining of what care should look like.
That's a tall order, but it's not impossible. And honestly, it's needed now more than ever. If we don't rethink this soon, we risk losing trust, not just in psychiatry, but in the entire healthcare system.
Couldn't agree more, Teresa. At the end of the day, this is about creating a system where patients feel seen, heard, and supported. It starts with acknowledging the gaps and asking tough questions about how we got here and how we can do better.
And doing better means being bold enough to try new approaches, whether it's more comprehensive guidelines, better clinician training, or simply making space for those in-depth conversations that we've all been skipping for far too long.
Exactly. It's not an overhaul we need, it's a revolution in care, Teresa. And while it's a steep climb, I'd say this conversation today is a pretty good first step.
Couldn't have said it better myself. Here's to the start of something meaningful.